All right, good. Okay, good to go. Thank you. So we have Gregory now. Thank you, Ellen. Yes, I'm a research officer with the Silver Chain Group. The Silver Chain Group is a not-for-profit organisation that is in the business of community-based care. So this is a nice lead-in, thank you, because we're coming from the other end. We provide services at home, and it is fantastic to see my friends and colleagues here from the community-based sector. So that's good. The Silver Chain Group is better known here in South Australia, though, as RDNS. So RDNS Home-Based Nursing Services, who have been providing nursing care for 120 years, are now part of the Silver Chain Group. And I'm from the research team, and our research team is led by Professor Jill Lewin. And Jill has really led the charge at looking at restorative care. And restorative care is short-term interventions aiming to restore function. So for people who have lost their function for whatever reason, they might be elderly and frail, but maybe have had a bout of flu. That might be all that it takes. A bout of flu can result in losing the ability to get out of bed. And so a short-term top-up, a burst of intervention to get people back on their feet again or to restore that level of independence is what we're looking at. Okay, so having explained where I come from, let's look at South Australia. 5.9% of patient days are occupied for maintenance care. The national average is 3.3%, but that is understandable because we do have an older population here in South Australia, and we do have slightly higher levels of disability as well. So it's not entirely surprising that our rate of bed occupancy for maintenance care is higher than the rest of Australia, but it doesn't make it a uniquely South Australian problem to be looked at. Now, maintenance care, as I just explained a moment ago, is really about the function of people and improving level of function for people who have disability or severe levels of functional impairment. So the important point here is that it's not for people who are sick or acutely unwell. It's not at the point that people have had pneumonia. Yes, they need the acute care while they're in the middle of an acute episode of something, but it's as they've come out of that, but then have nowhere to go, or then are not quite ready to go back home again. And so here is the issue. People with long-term care needs don't require just exactly 6.0 days of care, which, as you'll know, is the average length of stay for people in hospital. People with long-term care needs need care for 365 days, which raises the question, who is providing this care? And of course we all know the answer to that is that it's carers who provide care, and it's people's own resources themselves. People themselves can be quite independent, managing their levels of functional impairment, supported by carers. It's not always family, it can be friends, it can be other people. A whole network of community-based services that you'll see in a moment. And so when we come to the problem of people being stuck in hospital, it's actually a couple of problems. The problem is that it's not a nice experience for a person to be stuck in hospital. So it's starting with the patient, that it's not pleasant for people to be stuck in hospital. It's not pleasant for them to feel as though they're sort of on the scrap heap because they're not quite important enough. If a person who requires maintenance care sees the person in the bed alongside them getting all the attention because they're terribly unwell, and that's fair enough in the acute care setting, because obviously if someone's critically ill and all stations go, all of the resources concentrating on people who have the major illnesses, are unwell, are medically unstable, do need that rapid response when things deteriorate, is actually fair enough for acute care. But how does it make the person feel who doesn't have that sort of action adrenaline stuff going on, but is sitting there in the hospital bed and, no, sorry, the physio's too busy to see you today. And so then another day goes past where there's no physiotherapy for that person. So there you go. So it's the poor experience is a problem, as well as the fact that if there's nearly 6% of bed days occupied for maintenance care, well, we know what that's doing for the acute care. It's locking up the capacity, and so then you've got the bed block all the way back through the system, unable to discharge from emergency department, unable to admit to emergency department, ambulance ramping. So that's the effect of bed block. So the solutions here Transforming health, of course, comes into it, and there are some suggestions as to how this might be addressed. And nurse-led restorative care in hospitals, I'm pleased to see, I must say, because of the patient experience. For the patient experience, if we can concentrate the skills and expertise into Modbury Hospital, Queen Elizabeth Hospital, Noarlunga, and think of those centres here in South Australia as being centres of excellence for restorative care, I think that's actually a good thing. In terms of bed capacity, though, no, my prediction today will be that you'll see increased duration of care, if that's the only thing you do. So if we go to the target for transforming health of reducing duration of care, so that's that second problem that I mentioned, very likely nursing-led restorative care in hospital will do the exact opposite. You're likely to increase the duration of care. And the reason for that is health professionals, when they stumble into unmet need or stumble into really poor experiences of care, tend to want to do something about it. And so if it's their job to make sure that people are better prepared for discharge home, receive better care, they'll want to hang on to them late for longer rather than discharge ready or not, which is the poor quality of care approach. And I'm not just making this up because that's what the international evidence suggests as well. So the international evidence around nurse-led inpatient care for intermediate care is that the duration of care tends to go up. Which brings us to, well, what are we going to do here in South Australia? We already know that. We already have the international evidence suggesting that you're likely to get increased duration of care if it's only nurse-led care alone for people who have those care needs. Well, yes, we've got a solution right here in our grasp, which is to not just focus on what's being done in hospital. Let's look at the wider partnership. Why not do that? Let's look at what patients and carers bring into the mix. Let's look at what is happening in community-led restorative care and put it all together. Then you might be getting win-win in trying to improve the patient experience and do something about this bed capacity problem as well. So there's the melting pot, much like Robert, thank you, your Spaghetti Junction picture. I'll have to talk to you later about some modelling on this. We understand the problem for all those dedicated staff in the hospital whose business it is to try to get people out in a seamless manner and to be better prepared for discharge. And the thing is that whether or not people can be discharged home, again, is not necessarily related to what's happening in the hospital. It's related to all of this. What's happening out there in the community? What are the resources of the person themselves? What's the situation of their carer? Has their carer suddenly fallen over and had a fractured neck or femur? Are they themselves are stuck in another hospital? And so nobody can go home yet until it all comes together. So this is really quite well known. We know that there's a whole melting pot of factors out there. And we know that a lot of the work that is being done to support people with long-term care needs is already happening out in the hospital, out in the community sector. So we have things like transitional care, and there have been quite a few good benefits from transitional care, so we are seeing some good benefits. We do know that discharge planning is a good idea, that discharge planning, if you can try and tailor it and customise it, is likely to reduce the number of unplanned admissions. We do know that restorative care, for example, for home-based services for people who need personal care. That's my boss's Jill work. That's her work, by the way. Jill has done work in trying to promote independence for people who need personal care. And so we have evidence in. So we do actually have some evidence already for some of it, but not for all of it. So we don't understand everything, much as Adette was explaining earlier about the diabetes. We know some things, but we don't know everything. And we certainly see that it's a very big, messy world out there in terms of how much there is available. And of course, we need to be conscious that the people being supported who have long-term care needs, that's about 87,000 of them here in South Australia. Okay, so what to do about it? Coming to the research eventually. Sorry, I've been so slowly long-winded to get to the actual research idea. We have to involve patients and carers in anything we do. It really is a sensible starting point, because if I go back to that slide again, carers are at the centre of it. So we come back down here again, and remember what I said earlier about 365 days. We have a population here who require care for 365 days of the year. So it would simply be insane not to involve carers and patients in guiding our priorities and working out what are the important questions to ask, what are the potential solutions. We have to explore the patient experiences. I'm pleased that we've been getting the questions from the floor about patient experience because remember what I said a moment ago about bed capacity. That's not just it. You know, sometimes bed capacity and whether people have been able to be discharged home or how long they're staying in hospital or what's the proportion of days spent in hospital, they're quite handy indicators. So having a quantitative indicator is fantastic. I'll get to that later. But it's not okay to just look at that indicator alone unless you also look at the quality as well, because actually sometimes maybe a person needs a longer stay because it might not be even safe to discharge them home. Because, say, for example, there's an allegation of elder abuse which has not yet been resolved and fully investigated, then it would be very irresponsible and unsafe to send someone home. So we need to explore the experiences. And although I said that we do have some data about effectiveness of restorative care, which was from Jill's work, that's actually quite specific work, and there's certainly a lot more that can be done to find out how people are travelling with the care that they receive, both inside hospital and out there in the community sector as well. So having done that, looked at the factors, been directed from patients and carers as to what is important to look at. We can investigate the factors and then, where's John? Thank you, John, for your slide earlier, because looking at data and routine data is what I think would be a good idea. And I suggest that if we want to better understand the factors that affect maintenance care in hospitals, going to the big data sets and the routine data is a good way to do it, because we now have the opportunity with linked data, with the SANT data linkage, to look at routine data. And we can go back, say, maybe about 5 years on that and be looking at the bed occupancy for maintenance care, for example, or the length of stay, particularly for the population of people who've been receiving maintenance care, and do some regression analysis on all of the factors that have been feeding into that. And we can say, have they received nursing service? Yes, no. Then nursing service becomes an exposure for the people who are interested in methodology. Have they received other services? Yes, no. Keep it simple, because we keep it simple. Routine data type analysis like that, you don't expect to answer all of the problems and really get rich data, but you can start to hone in on where there may be some relationships that need to be looked at more closely. And having done that, it's then and only then that I think that we may be better equipped to start measuring the impact, because then by doing that sort of analysis first and going backwards in time, say, let's call it a 5-year snapshot view, and so we've got data with very large tens of thousands of participants so that we can track the data with, then think about, right, what do we think works? What do we think makes a difference? And then we can design our studies moving forwards to be working out which mixes of service in that mix of restorative care do we think are likely to make a difference. And I'm not a big believer in magic bullets, so I don't think we'll have magic bullets for these types of issues, which are almost wicked problems. But we may, hopefully moving forwards, have a little bit more information to inform that. So that would be good. And then we have to sort of keep remembering why. Why are we really interested in doing this? Well, we do need to sort of keep focused on being patient-centred. We do need to be safe. And really, we're not going to be able to really demonstrate that just on a wing and a prayer. We will need some information to inform that, and that's why it's nice to have sort of people who are interested in collaborating, because I know that I can't do this by myself, and I suspect that probably other people can't do it by themselves either. This type of an idea of a program of research is really calling for a collaborative effort, because it's not the type of work that any single person can do alone. So there we are.
Hi, I'm Donald Bramwell from the International Musculoskeletal Research Institute. I've just been grappling with a question that's been bothering me with a lot of this, that if we reduce lengths of stay, that's a benefit to the patients, particularly if there's a sort of comprehensive package of care that you have. But I was wondering, from the transforming health perspective, are the models of funding changing? Because if you've got a patient in a bed, it doesn't matter if it's the same one for a week or a different one every day of the week. So we get caught up in this idea of increased efficiency. Often we say it's going to be more efficient and therefore have a lower cost, but that doesn't always happen. We can be more efficient and increase patient care, but in fact not reduce costs at all, or in fact increase them because there's greater costs associated with having a new patient in the place. I wonder if any comments on that.
Yes. It's an excellent question, and I think it's even more complicated. I mean, in part, the activity-based funding in hospitals for the admitted care is intended to address that, because you're looking at the average price, so-called efficient price, average price being per diagnostic-related group, and so that's okay for the admitted care while in hospital. But it becomes much worse once you step into this sector here, because I think really what you've got is the cost shift problem, and there's not a lot of incentive to say, well, it will take money to get this person with disability out of hospital. And one of my friends who has a disability was saying, look, I've said to them, look, for this cost, for this person who's been stuck here for 6 months, we could have bought a group home by now, bought the whole house. And he's making a very good point, which is, actually, if you looked at the cost of keeping someone with disability in hospital for 6 months, then they could have bought the group home, staffed it, and done all of these things. But he bumped into that problem. Yeah, but it's not my budget. So that was the response at the time. We haven't improved a lot since then, I have to say, because we don't have the integrated funding across the whole sector, and again, I'm not sure that we ever will. And I think that it's a little confusing. On what's happening in aged care is quite exciting at the moment, because there are changes that happened as of 1st of July, which I forgot to mention earlier in the piece, and the changes to a more consumer-directed model for the home care packages is going to make a difference for people with maybe $5,000 worth of services, to get some cleaning, to get some personal care, someone helping with showering, but perhaps not at the high end. Yeah, so it's perhaps at those really expensive stays in the hospital. That, I think, may need some really high-level negotiation, I think, at public policy level, I suspect. They're just thoughts, anyway. Yeah. Thank you. Sarah down. Mm-hmm. Oh, and there's other changes too, like on the 1st of July. Consumer direction, I only mentioned one of them. The others are the morphing of HAC into home support programs, and of course the implementation of the gateway, the single point standardised assessment, single point of entry for the regional assessment services. So anyone with an interest in aged care, it's an interesting challenge to be working right now. Yeah.
Anna, Kushila Kumar from Flinders University. Thank you for the presentation. I'm just wondering whether part of this conversation should also be about having a cultural sort of mind shift about where care is accessed,
absolutely.
both from not just the giver of care, but also from the recipient of care, from the consumer perspective, from the health practitioner perspective. It's a cultural shift. It's a change in where we think care should be delivered, and it's the same thing in relation to education. We've always thought the tertiary hospitals being the best place to educate our next generation of students, you know, but that's changing because people are being placed out in the bush and getting wonderful opportunities to learn. So it's that same thing. I'm sort of wondering whether that's part of the conversation, and that relates to some of the comments being made as well about where the GP is fitting in this sort of process as well.
Yeah, I think you've just said it beautifully. I don't think I can improve on that other than to say that we have to be seeing our patients and carers as partners. They're not recipients of care, they're partners in care. And so what does partnership mean? If you enter into a business, partnership means negotiating the terms, more of an egalitarian basis, and understanding from all sides of what that means. But there's no point saying the word partner if then you say, oh, but you've got to do what I tell you. So, yeah, it is quite a big mind shift, I think. But I do like your idea of rethinking care and what that means and where it sits. And yes, I mean, obviously I have a heavy bias towards this sector, and you might have detected that a bit. I'm sure I will love a hospital on the day that I have a heart attack or have a stroke or things like that. But there's a place for all of it. There's a place for all of it. But I do think it's certainly the shift in thinking from the providers and how we view consumers is we've got a bit of a way to go to travel. Do you want to toss this off here?
I think so, don't I?
Yep.
I think
Okay.
I'd like to thank Anne, and then if everyone could stand up and stretch a bit.
Yeah. Thank you. Stand and stretch. Oh, I'm looking forward to your book. I might die thinking about it.